So my background at the Center for Addiction and Mental Health goes back to about 1992. It was then the Addiction Research Foundation. And I've worked in a variety of roles there as an addiction therapist, groups and individuals, in a leadership role, and more recently in the area of tobacco dependence. So over the years, I've seen lots of different clients and groups and worked with different kinds of issues. And today's focus on alcohol, I think, is especially timely, because when you asked for the show of hands, Tupper, it was pretty clear that alcohol surrounds us, right? It's been sort of integrated into our lives. And so what we're going to do this evening is really dig into it a little bit. So I'm really excited about this evening's topic, and I'm looking forward to your perspectives as well when we have some Q&A. So I'd like to just share a couple of quotes. And you heard on the alcohol playlist, I don't know if you noticed that there was a bit of a theme to those songs. I'll make sure to post the playlist as well tomorrow if you want to go and download those songs. But I think Frank Sinatra had many wise words. And it goes back a long time. For Plato to say it was a wise man who invented beer. And beer actually was invented far before the Greeks. Beer and alcohol and distilled spirits go back really, really far in history. So alcohol is certainly not new, and it's something that has been incorporated into just virtually every culture, almost every society historically has had some contact with some type of fermented beverage, and that's certainly true today. So I want to just say I have no commercial disclosures to offer you, except that I'm not the greatest cook. So I really liked this ad from Schlitz Beer from the 1950s where they're saying, honey, at least you didn't burn the beer, which I thought was appropriate. Okay, so as you go through these different weeks, I hope that tonight and in the succeeding weeks that you will have an opportunity to really start to think about some of the things, some new ideas, some things that come up for you. And I think the hallmark of any good course is that it asks more questions than it answers. So can I invite you, as we go through this journey together this evening for about the next hour and a half, to consider something that resonates for you. So what in what we talk about today resonates for you? And to also think about a question that you would like to think through. Because it may well be that there are questions this evening that I'm not able to answer. And in fact, that I couldn't answer. They may be questions that only you can answer. And I think sometimes those are the best questions. What I can promise you is that if any question gets asked this evening that's a fact-based question or what have you, a treatment-based question that I'm not able to answer, I have lots of colleagues at CAMH, and we'll certainly find that out for you. And then, in some ways perhaps most important, a seed that you could plant now. So what in what we talk about is something that may actually impact your own behavior or your own way of seeing things, and in this case, alcohol. So I think it's important to reinforce that today's talk is not really at all about, alcohol is bad, it's something that, you need to quit drinking, you need to cut down on your drinking. That really is for each individual to decide for him or herself. What it is really about, though, is just presenting the facts as they are, and some ideas that aren't factual, some ideas that are just that, ideas. And so I think those are sometimes the most interesting conversations. I'm looking forward to having that with you. So our learning objectives this evening are to consider what are the physical effects of alcohol, and I'll share that with you shortly. We're going to talk about low-risk drinking, and you'll have an opportunity to reflect on if you drink alcohol, how your drinking, or those you know, fits into Canadian drinking norms. We'll also look at why certain populations may be at higher risk for alcohol-related problems, and then I'll give you some resources where you can continue to access credible further information. Because if you were to go on Google, go on the internet, and search under alcohol treatment or effects of alcohol, how many hits do you think you would get? Like tens of thousands, hundreds of thousands of hits. So how do you sift through all of that information and actually locate information that's really credible? So we'll also talk about that. And if there are specific topics that you're interested in, I can also throw out some ideas of organizations or locations to access that. So how does that sound to you in terms of our learning objectives? So far, so good? Okay. So I'm going to show just a few images to open up. And as we look at these images, I want you to think about what kind of response does this evoke in you. So here's a young woman who's, dressed. It looks like she's going out to a party or a social occasion. She's holding a glass of wine. And what is that? What's your response to this? How would you interpret who she is? What she looks like? So intoxicated. What do others think? Having fun. What else? On the prowl. Yeah. And thanks for taking a risk and putting some of these things out there, because we have real cultural coding in images, and alcohol advertising uses these cultural codes very effectively, don't they? What if she was holding a bottle of beer instead of a glass of red wine? Might we think of that differently? What if she was holding a martini? So do you see how there's kind of different beverages even that get coded into how we present ourselves to the world? How about this image? What comes to mind? It's kind of stereotypical, right? These are stereotypes. The guy's watching the game, drinking beer, there's a pack of cigarettes on the table. And what about this image? Wouldn't we all like to be him? Sitting in first class with a glass of champagne on a silver tray. And so all of these different ideations of elegance, culture, celebration, partying, refinement, etc., all relate to different cultural perceptions about alcohol. And that alcohol, in fact, is really interwoven, isn't it, to celebrations and celebratory gatherings. Very much a part of it. So really, tonight is about asking, so what's all that about? What is this substance that we call alcohol? Now, before we really jump into the discussion about alcohol, I just want to say a couple of words about addiction. Oftentimes, when we think about addiction, we think of it as a binary construct, that you either have an addiction or you don't. The person is an alcoholic or they're not. And what I'd like to present to you is an alternative perspective on substance use that I'd like to use as kind of the organizing framework for how I'd like us to think about alcohol this evening. And that is to think about alcohol use and addiction along a continuum of severity. So at one end, you have people with no problems whatsoever. And at the other end, you have people with very severe problems. But there's lots of in between. It's similar to other kinds of chronic illnesses. Think about diabetes and hypertension. You may have people with no diabetes, no risk of diabetes, up to people with pre-diabetes, or diabetes that's controlled through their diet, to people with the very severe version of this illness where they're needing to inject themselves with insulin, multiple times per day and check their blood sugars, etc., multiple times per day. So similarly, we can think about alcohol along this continuum. And further, I want to also focus right here in the middle. This group of people who, from a population standpoint, actually have a proportionately greater cost to society in terms of social costs, economic costs, occupational cost, and risk. And if you look at it on this figure, you can see that at the severe end of the continuum, relatively few people, and I mean relative to the population as a whole, have severe alcohol problems. And the majority of people don't experience any alcohol problems at all. But what we have is this really big chunk in the middle that are at-risk drinkers or people who we might call problem drinkers. And so I'm going to share a couple of case examples this evening, and one of them will focus on what we might think of as a problem drinker, because those are the individuals who are not seen in addiction settings. They may be identified in a primary care setting if they're identified at all. And in fact, they would never say to themselves or anyone else, I have an alcohol problem, because they might be thinking about it from that binary construct of addiction. It doesn't make sense to call myself an alcoholic because I'm not, right? But on the other hand, they're not risk-free either. So it's that middle ground that we want to dig into a little bit and explore. Now, I also just want to sort of cover, where does alcohol fit if we think about different drug classes. So you're probably all familiar with these different classes of psychoactive substances from, maybe health class or science class. But if we can just do a really quick refresher, we have depressants, which of course include alcohol. What are some other examples of depressant drugs that would fall in this class? Benzodiazepines, absolutely. Anything else? Think about over-the-counter medications, cough syrups, etc. Also fall into that class of depressant medications. And it's important to think about what's in that class with alcohol, because I'm going to come back to this in a few minutes. Then we also have opiates and opioids, which are in a class all by themselves. Opiates and opioids are probably the most potent pain reliever ever discovered and continue to be used to manage pain more effectively than really anything else in the physician's arsenal of medications. We also have prescription forms of those medications. We've all heard about OxyContin, which was pulled off the market due to the abuse liability, replaced with Oxyneo, which wasn't formulated so that people couldn't grind it up. But of course, it only took a couple of weeks for the internet to be rife with how you actually are able to put it in the microwave and chop it up, etc. And methadone, which is a drug used to help maintain people with opioid dependence. And then we have stimulants. So examples of stimulants. What comes to mind first? Coffee. What else? What about illicit drugs? Cocaine, right? Methamphetamine. We hear all about that. Coffee and cigarettes, nicotine, and Coca-Cola or cola drinks would also fall into that drug class. Then we have the hallucinogens, and finally psychiatric medications. So I just wanted to give that quick run through because alcohol occupies this unique position as a depressant drug and interacts with other drugs in its category. So if you want more information, there is a nice 101 series that you can get online at the Center for Addiction and Mental Health on the website. And this is all going to be included in those handouts that will be posted online for you by tomorrow. Okay, so I think we are going to go to the bar for a brief time. So what I need is a volunteer from the audience to come and be a bartender. Is anyone willing to come on down? There might be a prize in it for you. Thank you. Come on down. What's your name? You can just say your first name. Stephanie. Yay, Stephanie. Okay. So, Stephanie, I'm going to ask you to step over to the bar. And could I get one more volunteer to order a drink? Okay, come on down. What's your name? Justin. Sorry? Justin. Okay, so Justin. With a D. Oh, Dustin. It's Dustin Hoffman. Okay. Come on down, Dustin. So Stephanie's your bartender this evening. And let's say that you're not ordering all these drinks for yourself, but your party of three is asking you for a martini, something else in a drink in that mixed drink glass.
Rum and Coke.
We'll call it a rum and Coke, even though it's going to come out of that vodka bottle, okay? but work with me here. And a glass of red wine. Okay, so go ahead and give your order, and Stephanie's going to pour your drinks for you.
Can I get a glass of red?
Yes.
A stiff martini on the rocks.
We have no rocks, and actually it might even be warm vodka, so I hope that's okay.
And a rum and Coke out of the vodka bottle, please. And what do I do now?
And actually, we'll just leave it here, but we'll let her pour your drinks first. Okay.
I don't think you don't want to drink that either.
Doesn't that look good, you guys? Is that not the most appetizing red wine you've ever seen? And look at that whatever blue beverage. That's fabulous. You're doing such a good job, Stephanie. Okay, and then Stephanie's now going to pour Dustin's other drink. Oh my goodness. Okay, don't spill that on your dress because we can't pay the dry cleaning bills. We're on a low budget. Okay. Okay, so let's give them a round of applause. Can we do that? And your prizes are, you can each select one of those books from the back table. The others are going to be raffled, but thank you for volunteering. Okay. Oh, he's going to give you a tip. Okay. We all heard that, Dustin. Okay, so we're going to come back to this in a minute. And what I'd like to do then is talk about, so we've seen these drinks that were poured. So when we talk about low-risk drinking, we have to talk about it in a kind of standardized way, right? Because what I say is one drink may look really different from the drink that you pour for yourself or the drink that someone else pours. So when we talk about standard drinks, we want to convert whatever I pour or you pour or anybody else in this room pours to a single standard. So I want to share what that looks like for you. So before I do, can I ask, who knows what a standard drink is? With respect to wine, for example. Go ahead.
5 ounces.
5 ounces of wine. And what about distilled spirits? 1 1/4. It's actually 1 1/2. 1 1/2 ounces. So you get an extra 1/4 ounce there. And what about beer? Yeah, like a regular 12-ounce bottle of beer. And what about fortified wine? So sherry, for example. That's a trick question. That's the advanced one. So that's 3 ounces. 3 ounces. And if you think back to, well, those of us who can think back to, the 70s or 80s or before that, beverage glasses were a lot smaller, weren't they? If you think about what a sherry glass looked like or a wine glass looked like, they weren't those big, huge balloon glasses that we're served now. And have you ever gone to a restaurant and ordered a glass of wine and thought to yourself, I think I just got ripped off for my 15 bucks because it looks like so little. So oftentimes when we're pouring drinks, we may be pouring above a standard drink. And we're going to measure in a couple of minutes whether Stephanie was actually pouring standard drinks. Okay, so here we have how each of those standards have the same amount of pure alcohol in them. And who knew that, those plastic cups at outdoor events, that they actually have standard drink markers on them. So if you're ever entertaining, you can know that that little line at the bottom, that's a standard drink of liquor. That the next line up is wine, malt liquor, and beer. So something to keep in mind. Okay, so I need one more volunteer to measure for me. So is anyone willing to come down? And now you know what's in it, so come on down. Measure the drink. Anybody willing? Someone with good eyesight. I'm at a point in my life where I have to take my glasses off to see close up, and I have to put them on to see far away. So that's why I'm really looking for some help here. Awesome. Thank you. What's your name? Sorry? Hunduk. Come on down, Hunduk. Okay, so which one should we measure first, you guys? What would you like to know about first? Which one? The one in the martini glass. Okay, so let's measure the blue beverage first. So that might be tricky to do without spilling, but don't worry if you spill a little bit on the tablecloth. Okay, so how many ounces is that?
It's like slightly above 4.
Okay, so just above 4 ounces. So how many standard drinks is that? Remember, it's 1 1/2 ounces per standard drink, right? So that's just below 3 standard drinks. Okay, here we'll just pour this off into this pitcher. Okay, next one, you can choose.
A little below 4.
Okay, so a little below 4. So what about maybe 2 standard drinks in that one? Okay, and last but not least. See, I'm ruining your fun, right?
Is almost exactly 4.
Almost exactly 4, so just below a standard drink. Interesting, huh? So it's hard to calibrate what is a standard drink. So I think we should give a round of applause. Thank you. And please, you can take one of those books from the table. Thanks so much for helping me out. So what do you think about that? How does that fit with what you understood or what your sense was? Any surprises?
You know, standard drinks differ from person to person too. If you weigh 98 pounds, then
That's an excellent point. What about weight? How does that impact what a standard drink does to you, or how does it affect the body? And we're going to talk about that. So I think that's a really important point. That one drink for a 110-pound female is going to affect her very differently than that same standard drink for a 200-pound male. There's no question. And in fact, I'm going to show you how women may be at much higher risk, actually, of not only intoxication, but other health problems and impaired driving. So these are the low-risk drinking guidelines that CAMH, in collaboration with other research-based organizations, have put forward. And you can see that for men, the drinking guidelines are a bit higher than for women. And partly that has to do with the fact that women experience more serious problems sooner from alcohol than men do. And it also has to do with the fact that women are more affected by alcohol. They get drunk faster and they stay drunk longer, as a rule, than men do. You also might notice that it's not like for women or 10 drinks per week, or for men the 15 drinks per week, that it's like you can save it all up for Saturday night. So the idea is that you're having a weekly limit, but also a daily limit. And you might also notice if you divide by 7 that, or rather if you sort of look at how you would work with those drinks, that you're going to have hopefully abstinent days. And that has to do with tolerance. That if you drink 3 drinks each and every day, the body is such that you will develop tolerance to the effects of alcohol. And that tolerance means that you're not going to get the same effect, and that sometimes people will drink more to get that same effect. So that puts you at higher risk of problem drinking. So the notion of having at least a couple of abstinent days per week is really to avoid the development of tolerance. Now, the low-risk drinking guidelines also talk about when it's not safe to drink, when those aren't low-risk guidelines. And so what times should people not drink at all? And I'm sure this is no surprise to anybody here that it's things like if you're driving, if you are pregnant, if you are operating heavy machinery, if you have a medical condition, or if you're taking some kinds of medications that interact with alcohol. Have you been to a pharmacy where you've gotten your prescription and the information sheet says, do not drink alcohol with this medication? So why do you think that might be? Why not drink alcohol? What would happen if you drank the alcohol? Exactly. So in some cases, it may make the medication less effective. In other cases, absolutely. It can amplify the effects. And that's something that we think of as potentiation. I'm going to talk about that in a second, and it's absolutely something to consider. So we've looked at standard drinks. What about drinking norms? So I'd like you to turn to the person next to you and tell them what your guess is of the number, or the percentage rather, of Canadian men who drink more than that 14 or 15 standard drinks per week, and Canadian women who drink more than than 14 standard drinks as well. Okay? So just what's your guess off the top of your head? Pull it out of your hat. Okay, let's see how you did. And if this were a gambling casino, then we'd be placing bets on this. But we're not. Okay, so drinks per week, men. How does your guess fit with this graph? So I'll give you a minute to just absorb the numbers on that graph. So we asked, what percentage of Canadian men drink more than 14 standard drinks in a typical week? And what do we see? 6%, exactly. So how does that fit with what you guessed? Well, let me ask this. Did anyone guess correctly within that ballpark, under 10%? Anybody guess less than 10% in this room? One person. Isn't that interesting? So some of you might be asking, excuse me, but where did these numbers come from? Like, did CAMH make them up to, imply that people don't drink? In fact, it actually comes from the National Alcohol Study. It's a Canadian study that's run about every 4 years. It actually deals with alcohol as well as other substances. And it focuses on, remember, all Canadians, all Canadian men. So if you're averaging in the 20-year-olds with the 60 or 70-year-olds, and then people who are middle-aged, you're going to get an average number. But nonetheless, some of you might be thinking, this still seems really low, right? And so let's look at, do you want to see women? Now you might want to revise your estimate. Okay, so where do women fit? So even less. And we know that women do drink less than men, as a rule. So this national alcohol study, national addiction study, is an anonymous telephone survey of about 13,000 Canadians. With a sample size that big, it's a pretty good survey. It's pretty reliable. Having said that, I was presenting this data to a group of clinicians, and one guy put his hand up and he said, "Excuse me, but I'm from Sudbury, and people drink more in Sudbury." And he is correct, actually. There are those variations across Canada. In fact, we see that in the East, people drink more than in the West. In the West, people use more illicit opioids than in the East, although that's starting to change with prescription opioids. People drink more in the North than in the South of Canada. So there are absolutely those regional variations. But just to get a flavor of where we fit in relation to Canadian drinking norms. And part of, I think, why it's so surprising to us is that alcohol is all around us. We talked about this at the beginning, that alcohol advertising is all around us. It's so integrated into our culture that it's really kind of hard to imagine that it is as non-prevalent as we might assume. And the other piece is that some of this, what we just did, has also been used in some research and treatment trials with college students, because college students often assume that everybody drinks heavily, and there's a lot of problems with binge drinking and alcohol use on college campuses. And so some of the interventions are actually focused in getting college students to survey themselves and then collecting that data and then sharing it with the whole group. And it's as shocking to those students as it was to us, when we did this activity, to see that it's actually not as prevalent as people assume. So when we think about those severely dependent people at the thin edge of the wedge, that often gets most of our attention. It's these people in the middle that may be drinking at problematic levels that are more numerous. So let's look at a couple of cases. So I want to share the case of Jolinda. So Jolinda almost never drinks at home with her family. Occasionally on weekends, she gets together with a group of her female friends, and they, have wine and conversation. And occasionally, when she drinks more than a glass or two of wine, she feels really drunk, really intoxicated. And she's kind of the one that the friends tease, because it's like, wow, she really can't hold her liquor. So what's going on with Jolinda? Why do you think that might be? How could she get drunk on 1 glass of wine or 1.5 glasses of wine?
Maybe the glasses are bigger than she thinks.
Okay, maybe they're not standard drinks. Maybe her friends are pouring her larger glasses. That's absolutely possible. I think that's a great point. What else?
Empty stomach?
Sorry?
Imagine they haven't eaten anything?
If she hasn't eaten anything. So is she having her alcohol on an empty stomach? And we're going to see in a couple of minutes why it is that you will get drunk faster if you drink on an empty stomach. You've probably heard or maybe said yourself, I'm going to have a glass of milk before I go out. It'll coat my stomach. And there is a bit of truth to that. We'll talk about why that is. What else?
She doesn't drink frequently enough to build up tolerance.
Precisely. That's the clue, right? She almost never drinks at home, but occasionally on weekends. So Jolinda has she has no tolerance. If she had a glass or two of wine 3 or 4 times a week, 5 times a week, chances are she would have some tolerance, and that glass or two really wouldn't affect her. But if she rarely or almost never drinks, has that glass or two, she's going to subjectively feel much more intoxicated. Okay, so in contrast to that, let's look at Alex. So Alex loves to entertain. He loves to socialize with his friends. His dinner parties are legendary for their fine wines and food. One of his favorite hobbies is shopping for hard-to-find ingredients and making fancy dinners. And if someone asked him, how many standard drinks do you have per week, what would Alex say?
He doesn't know.
Exactly. Just like what happened here. He'd be speechless. He'd be like, why are you even asking me that? It's just part of his life. And what do you mean standard drink? Who cares about that stuff? It's just part of his life. And yet Alex is not what anyone would consider an alcoholic in that kind of common parlance. He has a successful career. He gets up every morning and goes to work. His marriage is pretty good, although his wife nags him about his drinking. And although he drinks a lot on many occasions, people don't really see Alex drunk. He doesn't ever really look drunk or act drunk. So how can that be, based on what we talked about?
Maybe his friends are drunk too.
So maybe his friends are drunk too. So Alex is just kind of fitting in with the crowd. Yes? He has a higher tolerance. So Alex, his daily drinking is regular. It's routine. It's so integrated into his life that for him, his level of tolerance is such that he just doesn't feel intoxicated. He doesn't act intoxicated. But here's the thing. I was one of the folks who developed the treatment program manual for Ontario's Back on Track program about 10 or 15 years ago. And I don't know, it's probably, if you don't know about Back on Track, that might be a good thing, because it's actually anyone who's convicted of impaired driving in this province has to pay about $500 to take a remedial course. And the idea is to help reduce recidivism. And when I used to do training of other providers in the province on Back on Track and run some of those pilot groups, it was very interesting what people would say, because we would get a real cross-section of folks coming into those courses. There would be people who, occasionally drank, and that one night they got drunk and got behind the wheel and took a risk. But most of the people are kind of repeat offenders, what you might call people who like to gamble, who haven't been caught perhaps for years and then kind of got unlucky. And in almost every course, one of the themes was, I drive better drunk than most people do sober. Isn't that interesting? Slightly frightening, right? But what that comes from is not because the person is, just a terrible individual. It comes from a misapprehension that somehow, because I might not feel intoxicated or impaired, that I'm not impaired. And that has to do with tolerance. So that's why I really want to emphasize that piece. And when we think about those low-risk drinking guidelines, that's why we want to also be thinking about those abstinent days, because tolerance is not really a good thing. And yet in college, when I was at Queen's University, my undergrad, people would talk about so-and-so can really hold his liquor. He's got a good constitution. Actually, it was because he was tolerant to the effects of alcohol, not because there was anything, stronger about this person. There are some genetic variations among fast and slow alcohol metabolizers, so I certainly don't deny some people do experience the effects more than others, but for the most part, we can think about tolerance. We also want to think about cross-tolerance. So remember, we looked at alcohol in a class of drugs called depressants, and depressant drugs, depressant plus depressant, 1 + 1 does not equal 2. As we heard earlier, it potentiates the effects of those substances. Okay. How are we doing so far? Okay. So why don't we talk about absorption and metabolization and the effects of alcohol, and then we're going to get to the treatment stuff. Does that sound reasonable? Any questions before we jump into that?
I'm just a little confused at how tolerance works, because the amount of alcohol is still in your system. Is it that you mask it better, or?
It's a great question. So how does tolerance work if that amount of alcohol is the same? How can that be that someone feels drunk, someone doesn't? And it really has to do with the psychoactive properties of the alcohol. So it's not, when we measure blood alcohol content, we're not measuring anything to do with the psychoactive perception of whether I'm intoxicated or not. What we're measuring is simple blood alcohol. But how the brain adapts to the presence of the drug is what tolerance is really all about. And our brains are incredibly complex and beautiful organs that will adapt and self-regulate to the repeated administration of psychoactive substances. Another example of tolerance would be nicotine. The first time, I don't know if anyone here has ever smoked a cigarette, but anybody remember the very first cigarette they smoked or the very first few puffs? What happened? Sick, dizzy. Some people might have vomited, and that's to do with tolerance. So actually risk for tobacco dependence among youth is, I think, about 60% for that person after the first complete cigarette has been smoked, because it actually takes us quite a few tries before we can smoke a whole cigarette without throwing up or feeling really sick and dizzy. So you notice how there needs to be that period of acclimation and tolerance. It's the same with opioids. It's the same with really almost any psychoactive medication or any psychoactive drug or medication. It's a great question. Okay, so let's think about absorption. So, well, we know that we drink the alcohol. It comes into contact with our mucous membranes. It goes down our esophagus into our stomach, and most of the alcohol gets absorbed through the small intestine, about 20% through the stomach. And that's why, if you, as we alluded earlier, if you eat before you drink, then your stomach's going to be full of food, and it's going to take longer for that alcohol to pass into the small intestine, and there's less surface area, if you will, in the stomach for the alcohol to be absorbed. So it's going to get digested along with the food and empty more slowly into the small intestine. If you drink alcohol on an empty stomach, you can imagine it's getting absorbed very quickly and then right into the bloodstream. So that's why you'll feel that effect. If you have a drink on an empty stomach, you get the effect much faster. Now, alcohol is absorbed into the bloodstream. And what's the bloodstream mainly made up of? Water, right? So when we think about the difference, gender differences between men and women, if we think about the ratio of fat, body fat, to body water, which gender tends to have less muscle and more body fat? Unfortunately, right? Women. Another raw deal. We have, as a rule, more body fat than men. And what that means is we have proportionately less body water. Does that make sense? So if you think about it as a simple ratio, because we're talking about blood alcohol concentration, right? Not fat concentration, like the alcohol is not going into our lipids, like benzodiazepines and cannabis, for example. Those metabolites get stored in our fat. Alcohol gets excreted from the bloodstream, metabolized, and we're going to talk about that in a second. So what that means is that the same weight of a male versus a female, unless she's super fit and lean, chances are she is going to have a higher blood alcohol content relative to that guy. And that's because she has less body water than he does. And that's important because what we're seeing now in some of the college surveys around alcohol use is that females are now starting to drink as much as guys. And that's higher risk for them. And we'll talk more about that in a sec. So then once the alcohol gets absorbed, the body starts going to work metabolizing that alcohol. And so let's look at how that, let's do just a little really mini, I promise you short, chemistry science unit. Okay, so the chemical name for alcohol is ethanol. And alcohol gets first pass metabolism from an enzyme, a digestive enzyme called alcohol dehydrogenase. Alcohol dehydrogenase is in the liver, and it metabolizes that alcohol into acetaldehyde. Acetaldehyde is important because acetaldehyde is poison. It's toxic. The body doesn't like it. It's associated with cancer. It's associated with other nasty things. So the body wants to get rid of that acetaldehyde as soon as possible, clear it from the system. And so it gets broken down very quickly in most people by another enzyme called aldehyde dehydrogenase into acetate and then to carbon dioxide and water. So, and there's a couple of other enzymes too. They're not that important for our discussion purposes. But I guess the piece I want to also share is that there are important genetic differences among us, among populations, among individuals. And some people are what are called fast metabolizers of alcohol, and some people are what are called slow metabolizers. And slow metabolizers, when they drink, will often get a flushing reaction. People of Asian descent, people of Asian descent experience a real flushing reaction, red cheeks and heart palpitations. And that's actually a protective factor because it may be more unpleasant, that feeling of drinking, but not in all cases. Ironically, slow metabolizers are more at risk of the negative effects of alcohol than fast metabolizers. And that's because that acetaldehyde is sticking around longer in the body. Does it make sense? Okay. So basically, the body is a funnel. You can pour a lot in a really short period of time, but it's going to come out in a slow and steady rate. So I want to show you what a blood alcohol curve looks like. And so here's this hypothetical person who's been partying pretty heavily. So they start drinking at 9 p.m. They stop drinking at 1:30 in the morning. And you can see that the blood alcohol is continuing to rise for about 30 minutes after they stop drinking. And that's why? Why does it continue to rise? It's still in the stomach or in the small intestine, exactly, so it's still being absorbed. So when you stop drinking, that doesn't mean that there's no more alcohol to still come, right? So then the person thinks, oh my gosh, I have to get up for work tomorrow, I'm really hungover tomorrow, it's 2 o'clock in the morning. So then they get up at 7 o'clock, they get ready, they jump in the car, and it's 7:30 in the morning, and what's their blood alcohol level? Can you see that slide? 0.08. Oops. Okay, now I'm working, or rather driving to work, I'm a little bit late because I had to stop and get coffee. It's 9:30, what's their blood alcohol level? It's still 0.05. And in fact, that alcohol isn't cleared from their system until 1 o'clock in the afternoon. Now, the point I want to make about that is how many people do we know who have had a heavy night the night before, gotten up the next day, and gotten behind the wheel? Not even thinking, wouldn't even occur to us. And the reason for that, again, has to do with our own subjective perception of intoxication, not to do with blood alcohol concentration. That on the upward curve of that blood alcohol curve, we feel more intoxicated than on the downward curve. At that 0.08 level, at about 11:30 at night, the person is feeling great. They're feeling no pain. At 7:30 the next morning, at that 0.08 level, they are feeling pain. They're not feeling good, and they're not feeling what they would consider as intoxicated. They're feeling hungover, but they're in withdrawal. A hangover is basically alcohol withdrawal. Any questions about this? Okay, so let's dig a little bit further. So on the Canadian Auto Association website, there's a blood alcohol calculator, and there's lots of them out there on the internet. I've looked at a few. This one's pretty good. What you need to understand is that they are all hypothetical, okay? This is not a tool to assess for yourself. So you've been drinking, you go online, you enter your weight, how much you drank, and see if it's okay to get behind the wheel. Trust me, that's a really risky proposition. I don't recommend it, okay? So this is totally hypothetical because there are important individual differences that this kind of thing can't calibrate. But it does give us a ballpark figure. So this guy weighs 180 pounds. He drinks 5 Canadian beer, 5% alcohol, over 4 hours. And what would you guess his blood alcohol level would be? Just ballpark. Anyone want to hazard a guess? 0.06? You're so close. 0.0554. Very close. Okay, let's look at the female. So she's 150 pounds. She drinks 4 gin and tonics over 4 hours. What do you think? So she has 1 less than the guy. What do you think her blood alcohol would be? I heard 0.06. Same? 0.0875. And then the other thing I want to highlight about that is depending on who's pouring the drinks, and Stephanie, I don't mean to pick on you, but if you were pouring those gin and tonics, it might well be that she subjectively assumes she's only had 2 drinks over 4 hours. And she's been told that if you have 1 drink per hour, you're okay to drive. Well, she's had only 2 drinks in 4 hours, so for sure she must be okay. So I guess the take home from this is that women actually may be at higher risk of impaired driving than men in many cases, because we don't necessarily understand the impact of those gender differences, sex differences, in alcohol's effects. So let's look just briefly at some of the physical effects of alcohol, and we'll start with the brain. So we'll need a bigger brain than Homer Simpson's brain. But so what is it about the brain that is just so calibrated to want alcohol and other psychoactive drugs? And it's this area in the midbrain called the mesolimbic dopamine reward pathway. We've all heard about dopamine. That's the reward drug. That's the endogenous reward that makes us feel good, right? From both substances, but also from other kinds of behaviors that we have evolved to seek out in order to perpetuate ourselves, in order to survive. So that mesolimbic dopamine reward pathway is also the reward center for procreation, for sex, and for food. 2 very important behaviors if we're going to survive as a species. Well, psychoactive drugs also act on this very same area of the brain. And so if you consider that, when we think about alcohol cravings or drug cravings, it makes sense that people experience them as a true drug hunger. If you had not eaten all day today, and yesterday you ate lunch but not dinner, and someone pulled out of their bag a big hamburger that they bought down the street at one of those fast food places, and then they pulled out some fries with that, and the smell of that food was just permeating the room, how would you feel? Would you be a little distracted by that? Right? Would you be like thinking, oh my God, my mouth is watering, like maybe, where did you get that? Can I just like sneak out for 5 minutes? And what if you had not eaten for 3 or 4 days? And then what if that person actually got up to just, go outside for a second and that burger was sitting there and you hadn't eaten for 3 or 4 days? Might you sneak over and just steal a bite of it? So when we talk about, some of those stereotypes of the addict as liar, thieving person, all of those stigmatizing negative stereotypes, I think one of the things that I really want to highlight is that alcohol addiction and other drugs of abuse are being understood now as chronic conditions of the brain, chronic brain diseases. Because what those drugs have done have actually hijacked that brain pathway. And the brain has been recalibrated, that reward system has been compromised. So when we talk about, willpower or just say no, or all of those messages, those very simplistic messages about stopping substance use, this more sophisticated understanding of addiction, I think, helps us understand why that's probably not very realistic. Now, the other beauty of the brain, though, and of human behavior, is that we can change against all odds. So it's not certainly to say that, once someone's addicted, they won't recover because their brain is compromised or hijacked. We know that people can and do recover. It just takes a lot of work, and maybe more, I think, than people who have not experienced addiction problems might appreciate. Okay, what about the heart? So how does alcohol affect the heart? And there are a number of different impacts that alcohol can have. In fact, one of the interesting things is that when we think about the effects on the body, what's the first organ that you think of? The liver, right? Because that's what goes to work metabolizing. But it's actually also has some real impacts on the heart. So arrhythmias, strokes, hypertension. Cardiomyopathy is the weakening of the heart muscle. Arrhythmias are the heart not beating properly and pumping that blood. And if the blood is pooling in areas of the heart, that can lead to clotting, that can lead to strokes, etc. But the other piece is that even binge drinkers, so not just chronic long-term heavy drinkers, but binge drinkers are also more likely to experience stroke, irrespective of the effects on the heart. And you might be saying, so what? I thought alcohol was good for my heart. So then you're like, how can alcohol be good for your heart and bad for your heart? So here's the answer. That moderate alcohol consumption is associated with beneficial effects on the heart. But who is at risk for, heart disease or heart problems or hypertension? Is a 20-year-old at risk for these things? No, the 20-year-old probably doesn't need to drink moderately, right? It's probably someone who's 50 years of age or older, male. So the key is moderation. The key is also, who is it? Is the person at risk? And that if the person is at risk for alcohol problems, they can probably improve their heart health in safer ways than by drinking. For women, it's a little bit trickier because we know that women are more impacted by alcohol use, and that actually for women it might be that the lower risks of heart disease may be offset for higher cancer risk. There's some evidence that even as little as 1 drink a day can raise a woman's risk of developing certain kinds of cancer. So it really is a trade-off. It's just not fair that for women we have these telescoping effects. The other piece is that people who drink, especially drink heavily or regularly, tend to be more likely to also smoke. And we talked about potentiation, that alcohol plus tobacco potentiates the cancer-causing properties of both of those substances. Okay, so just in terms of those telescoping of effects on women, we see that alcohol can, cancer of the mouth, and this is true for men as well, but sooner and more likely for women relative to men drinking at the same rate. Liver cancer, colon cancer, breast cancer, and about 11% of all breast cancers are related to alcohol. And that's partly because of alcohol's effects on hormones and on estrogen. That's the hypothesis of it. And as we talked about, it's acetaldehyde. Remember that first metabolite of alcohol, the acetaldehyde is the poison that is hypothesized to be related to cancer. Okay, and then, isn't this fun? Aren't we just having so much fun? We're talking now about, okay, we're almost done this part. The liver, so you've heard about fatty liver, fat deposits on the liver, alcoholic hepatitis, scar tissue can form. So some of these earlier ones are reversible. The person stops drinking, but with the continued drinking, they can go on and develop more serious issues like cirrhosis, also associated with some of these other unpleasant things. And that about 90% of heavy drinkers will develop that fatty liver, that steatosis. I was going to ask who knows what that organ is, but it says pancreatic risks. But when I was looking for a picture to put in the slide, I was thinking, I actually never really thought about what the pancreas looks like, and it looks kind of like a little worm. Anyway, you don't need to worry about this as much because only about 5% of heavy drinkers would develop pancreatitis, and the jury's out on whether it's like what combination of environment and genetics make that 5% unlucky enough to develop acute or chronic pancreatitis. But that's something that we wouldn't, might not be the first thing that comes to mind. And then last but not least, the immune system. So have you ever heard of, or perhaps yourself, if you have a really bad flu or a cold, the remedy of the hot toddy? I'll have the rum hot toddy, the rum with lemon and honey and syrup and what have you. And that actually alcohol suppresses the immune system or compromises the immune system. So if you're trying to fight an infection, you're actually not doing yourself a favor, although you might feel better due to what? The psychoactive effects, right, of the rum toddy. But it's not because it's actually curing your flu or your cold. Okay. Yes?
Were you in that section there?
Yes.
The one that really bothers me is fetal alcohol syndrome.
Yeah?
Do you want to discuss that?
Sure. Did you have a particular question about it, or?
This seems to be the really bad one because is it permanent, the damage to an infant?
Thank you for asking that, because fetal alcohol syndrome is probably the most pernicious and yet of all preventable cognitive and physical disabilities that people are born with. Alcohol is a teratogen, meaning that it does impact the normal development of the fetus. Fetal alcohol syndrome or fetal alcohol effects, as they're also, because it's not necessarily just the full-blown syndrome, it might just be subtle effects depending on the quantity that the mother has consumed and duration of her consumption during her pregnancy are permanent. And I think one of the issues is that this condition is really underdiagnosed because there aren't such great, easy to use, clear, crisp screening tools for it. There are for people at the very severe end of that diagnostic range. So we see that some facial anomalies and some other different physical characteristics, as well as the cognitive deficits and behavioral issues that accompany that disease or disability. But in its less severe forms, its subtler forms, it's really hard to diagnose. So I'm glad that you brought it up because it's something that I think we need to pay more attention to, both in primary care settings as well as from a public health and policy perspective. It's a really great point. Yes?
In the previous section just now, when it was referring to heavy or moderate drinkers, is that lining up with like the standard drink amounts that we had talked about earlier? Or?
Yes, thank you so much for clarifying that. So this is actually one of the shortcomings in a lot of alcohol research, is that research scientists define what's heavy, what's moderate, what's light, what's frequent, what's infrequent in some different ways. So that makes it a little bit hard to compare across studies. But for all intents and purposes, you can think about heavy as probably like 20 drinks and above per week. Moderate drinkers would be within the recommended guidelines, pretty much, maybe slightly above. Light drinkers would be at the lower end of those guidelines. But that's just very general because each study has its own criteria. And there has been a call for researchers to kind of standardize. Here's how, let's have one common definition. But that's like herding cats, right? You got all researchers to do the same thing. Any other questions? So we're going to talk about treatment approaches now. How are we doing for time, Tupper?
I've got 8:07.
Okay. Okay, I think actually we're just in great time. Okay, so when we talk about screening and treatment, there's a really big book called the DSM, the Diagnostic and Statistical Manual. And this is really the go-to resource that lists every kind of mental health disorder and all of the different diagnostic criteria that a psychiatrist would need or physician would need to make a diagnosis. It's currently undergoing, there's a lot of excitement in the field of medicine and psychiatry right now because it's currently undergoing a major, major revision, huge revision. So there's all kinds of infighting and web postings and avid discussion about the DSM and the DSM revision. So trust me, this is very exciting to many people, even if it's not super exciting at 10 after 8 on Thursday night. But I think what the take home for this purpose is that in the new revision, which is expected to come out sometime next year, that there were previously two classifications, two kinds of alcohol and substance use disorders, alcohol dependence and alcohol abuse. And both of those are now being combined into one single unitary diagnosis called substance use or alcohol use disorder. Okay? So that's just a flag, and there's the website there, dsm5.org, if you're fascinated, you want to read more about this. But let's, remember we talked about Alex earlier. Why don't we go through a brief DSM checklist, and let's diagnose Alex. Would you like to do that? Let's see if how does Alex stack up? Okay. So you're the psychiatrist, so you've gotten this brief case history. So has Alex, within a 12-month period, failed to fulfill major obligations at school, work, or home? No, he goes to work every day. He's, active in the community, etc. Has he recurrently used alcohol in hazardous situations, impaired driving, drinking while mowing his lawn, or what have you? Okay, no. Does he have persistent social or interpersonal problems? His wife nags him, right? So could we call that yeah. I mean, that's a question mark. How bad is the nagging? So that's why substance use assessments take a little bit of time, because we want to find out more. We're not sure. That's a question mark. What about tolerance? Oh, yes, no doubt about that. What about withdrawal? Would he have severe delirium tremens if he stopped drinking? Well, people with very severe chronic heavy use, and we'll get to this one in the checklist, tend to always have alcohol in their system. And those are people that if they were to have emergency surgery, for example, would be given a medication to make sure that they didn't go into withdrawal during that surgery. So withdrawal, I think severe withdrawal, hangovers, yes. Severe withdrawal, probably not. But depending how conservative we were, and there's very few absolutes in this field. So some practitioners might even put a question mark for that one. Does he use for longer than he meant to? And does he drink more than he thought he was going to? Does Alex ever say, oh, I'm only going to have 2 drinks and drink 6 drinks? I would put a question mark. I don't know. Maybe he has a big meeting the next day and he says, oh, I'm only going to stay, I'm only going to have a couple drinks, and he ends up drinking 5 or 6. So we're not sure. He doesn't have any evidence of trying to cut down. I think we saw that from the case. It's not like this is for people seeking substances and spending lots of time. Their whole day is focused on finding the drug, taking the drug. Has he given up important activities? Well, here's why I would put a question mark. I would wonder, if he's drinking that regularly and that much, is he missing out on certain things? Does he have kids? Does he ever miss stuff the next day on a weekend if he's drinking heavier, etc.? So I would just query that. Continued use despite knowing that problems will become worse. Maybe no one's ever told Alex, you could have pancreatitis or liver cancer or what have you. So at this time, no. If a physician or another practitioner said, your liver enzymes are up, they're elevated, you really need to cut back, and he continued to drink, then we would check that off. And then craving, strong desire or urge. If he tried to quit, he might have that strong urge. So question mark. Now, chances are we're not going to play psychiatrist and do this with every person or what have you. You probably came here tonight wondering, just give me something quick. I just want something quick and easy. So I'm going to give you 3 strategies, okay? And it's actually 2 strategies because I'm going to suggest you combine 2 of them. And this is anyone can use these screening tools. There's no special training or course you need to take, and they're really simple. So the first is to combine just a query of how much and how often with a 4-item questionnaire called the CAMH questionnaire. So let's look at quantity frequency. Let's screen Alex. So how many days per week did Alex drink over the last month? He drank, there's not 30 days in a week, but he drank every day, right? On a day when Alex drinks, how many drinks would he say he had? Do you remember from the case? I think it said 5 or 6, or 4 or 5, we'll say. And then how many times during the last month did you drink more than 5 drinks, binge drinking? So Alex is going to say on weekends, pretty much he'll drink a little bit more. Then we want to ask the CAMH, okay? So the CAMH is an acronym that stands for each of the 4 kind of key pieces to it. Have you ever felt the need to cut down? What would Alex say? No, of course not. Have you ever been annoyed at people criticizing your drinking? Yes. Have you ever felt guilty about your drinking? No. Have you ever had a morning eye opener, a drink first thing in the morning? Maybe when he was in Mexico on vacation, but as a rule, no. Okay, so you can see how if you just use the CAMH, because it says 2 or more yes answers is clinically significant, there's some different cut points. Some organizations use 1 yes answer, and now you can see why. But if you combine the CAMH with the quantity frequency, that's a pretty good screener. Do you agree? You get a pretty good sense of that. And then the third one I want to show you is really easy. It's just 1 item, 1 question. How many times in the past year have you had 5 drinks for men or 4 drinks per women in 1 day? And in a score of 1, more than 1 rather, identifies unhealthy alcohol use. So for Alex, we have to do a little multiplication. 6 times per month times 12 months equals 72 times. Okay, so clearly on that single item screener, which a primary care physician might use, Alex would screen as unhealthy alcohol use. Does that make sense? Yes?
Do you have a graph that shows more of the spectrum?
Of what?
Because I'm thinking that an answer of 1 identifies unhealthy alcohol use is quite low, and a lot of the population that
Yeah.
what do doctors actually use on the spectrum?
That's a great question. And well, remember the ruler I showed at the very beginning, it's really just a continuum. And unhealthy doesn't mean addiction, right? Unhealthy just means at slight risk for someone who maybe does this 2 or 3 times a year. So it's going to elevate the risk slightly. 72 times during the year is going to elevate it even more. So it's really just about risk. Yeah.
So I have a question about the word day. So there's 24 hours in a day.
Right.
So it's like, say, you go to the cottage and you might start your morning with Baileys and your coffee. Why not, right? And then you'll have a beer starting at 11. One beer, an hour until, say, 3 o'clock. You take a break, go for a swim. 5 o'clock, you have a gin and tonic for a cocktail. You've got a glass of wine with your dinner. But the drinking is like spread throughout, say, the day, and it's, there's hours throughout the day when you don't drink. So if I see 5 for men in a day, that doesn't seem like an awful lot to me. And 4 for women in a full day. Now, if you say 4 in an hour or 4 in 2 or 3 hours, that seems like quite a bit. So I don't know.
I think that's a really great point. And again, it really relates to risk. So the cottage. You don't go to the cottage every single day throughout the year. It's a vacation. It might be on the weekend or what have you, and it's limited by the seasons. The other piece is that a day, for the purposes of this screening, would be from the time you wake up till the time you go to bed. So it would count. But again, it's all about context. And I think what I love about these questions is that what you're getting at is that this in itself is not enough to tell us this person has a problem, they need treatment. All it is a little flag to just investigate it further. That's really all it is. So I think that's an important qualifier to these screening tools, that it's not like now you have the power to know who has alcohol problems. That's not true. What you can do is ask a few questions and get a sense of, is this something to maybe look into further? And that's really all a screener is. The other problem with screening tools is the whole issue of their sensitivity and specificity. In other words, how many false positives does a screening tool get, and how many false negatives does it get? And so there's always going to be that balance. The more sensitive you make it, the more false positives you're going to get. The less, the more false negatives, etc. I thought I saw someone else had their hand up. Okay, I'm conscious of the time, so why don't we skate through these last and then we'll wrap up. So I just wanted to share a couple of psychosocial treatment resources with you. And if we think about Alex, and in fact anyone else along that continuum of severity, one of the pieces I just wanted to share is that oftentimes in the media when we talk about addiction treatment or alcohol treatment, we think about 2 things, AA and rehab, right? Like that's all we hear about. And yet, if you look at this whole continuum of different options, most treatment programs are outpatient and may in fact be very brief. And I think, it does an injustice to treatment because what it does is actually is a disincentive for people who have problems to seek help because they may not want to, sign up for lifelong recovery. They may also not want to go into rehab for a month and get out of work or what have you. So I think it's just really important to note that especially for people in that moderate range that we've been talking about, that brief outpatient interventions have been shown to be equally effective as more intensive interventions. And how we can kind of match people, and there right now is no perfect algorithm to scientifically match people to the best treatment, the one that's guaranteed to work. But if we look at this kind of general problem-solving model that was proposed by my colleagues Wayne Skinner and Garth Martin, many years ago now, still being used, that we can think about it as a matrix. So let's think about Alex. How severe is his alcohol use? Is it low, moderate, or high? What do you guys think? Moderate, right? So we'd put it somewhere between low to high. And how many co-occurring problems does Alex have? Do you say low? Like he's employed, he doesn't have a lot of other issues going on. And what about his social support and his stability? High, right? So you can see that from this matrix, where would he fall in terms of appropriate treatment? We're not recommending that Alex go to, a 30-day or 90-day residential program. Brief outpatient or outpatient treatment may be all he needs. And that, in fact, may be effective at helping him resolve his issues if he chose to get help for that. Now, you can actually connect through Connects Ontario, which is a really great resource around problem gambling, mental health, and substance use. And it's available for free to the public, and it has a really rich list of all of the different resources that are available in this province. And CAMH also has a really rich array of programming if you're from the Greater Toronto area. And we now have a front door, centralized access, finally. Some of you who have, maybe referred people or had experiences or contact with CAMH may have found it a little frustrating to find the right program. So now there's one centralized number for intake. But what if the person doesn't want to get help? What can we do? So I have two ideas to leave you with, and then I'm going to close. The first is a book that I really recommend. It's called Get Your Loved Ones Sober, Alternatives to Nagging, Pleading, and Threatening. It's an evidence-based approach based on a community reinforcement protocol that was developed in the US. It has a really robust research base behind it. This is a self-help book for family members or loved ones, and it is written in such accessible language with lots of case examples, a really supportive tone, a super easy read, and it's very practical. So I keep a copy in my office, and I have to often keep getting them again because I keep giving them away, because this is just a highly, highly recommended resource. The other is the Alcohol Help Center, which was developed in collaboration with an online development company and a senior scientist at CAMH by the name of Dr. John Cunningham. And his interest is in how do you motivate people to change their behavior by giving them brief, personalized information that's completely salient to them. So in closing, I'd like to just walk you through the kind of feedback that Alex would get if he logged on to the Alcohol Help Center. So he's refusing to go to treatment. His wife is really pushing hard. She's trying that book, but it's not working very well. So she's given him the website. Alex is by himself. He's kind of bored, so he has a glass of wine beside the computer, and he goes online. So how does your drinking compare with other Canadian men in your age group? And it's totally neutral, right? So Alex sees that for men of his age in Canada, that he's in the top 6%. Then within the last 12 months, you reported drinking on approximately 100% of days, approximately. And you reported that you drank a total of, and what do you think the total, because it's going to extrapolate. Alex completes a short 21 question of typical drinking in a week, and then the computer extrapolates that out to a year. So what do you think the total number of drinks that he had last year was? It's kind of like counting to 1 billion, right? It's like all a guess. So he drank 2,080 drinks last year. And how much do you think Alex spent? So the computer's now going to calculate for him. Take a guess? What do you think? 10,000, 2,000, 15,000? About $10,400 in the last year. Okay, so it's kind of motivational, right? Like we're getting motivated. Yes, Alex, you could say. So, and then it talks about calories. You consume about 500 calories from alcohol each day. This could translate into 59 pounds. Alex is, works out a lot, but and then you reported that the greatest number you had on one occasion was 12 drinks. It also gives a graph of drinks per day for males your age from Canada compared to you. Do you see how Alex's graph fits with the norms? He's a little bit higher than those other graphs. So, and then it also incorporates the Alcohol Use Disorders Identification Test, which is a clinical tool. It's like a brief, just a few different items are put into those questions that Alex has answered. So it gives him, based on this diagnostic screener, a result of harmful drinking. And then we're almost at the end here. You reported you weigh 160 pounds, so this means it would take about 19 hours for that alcohol to be metabolized. And then, I love this one. How many hours do you think Alex spent under the influence of alcohol in the last year? I think Dr. Cunningham is brilliant. Like, he came up with all of these ways to, motivate. He's been working on this for about the last 10 or 15 years. About 4,004 hours under the influence of alcohol. So the idea is that not everyone will be motivated by all of this feedback, but that if there's even just one or two things, for some people it might be the calories, for some people it might be number of hours under the influence, for some it might be the money. I had a client who said, my wife and I have been saving up for the last 10 years to buy a bed and breakfast. That is our dream. And when we did this tool together, and he saw, and I think his total was about $15,000 a year, his first reaction was, that's my bed and breakfast. Like, that was all the motivation he needed. In fact, he didn't even need to come and have further sessions with me. He was inspired. So the idea was that if we can give people information that's truly salient to them, this can help them move forward. So hopefully, Alex has something to think about. Okay, so a feature that resonated for you, a question you want to think through, a seed that you could plant now. I'd invite you to think about that.